You probably already know a lot about atrial fibrillation, but I'm going to talk about it as if you don't, just so we don't skip over anything. Atrial fibrillation is an abnormal heart rhythm in the top chambers of the heart where there's chaotic electrical activity. So instead of having a nice coordinated wave of electricity that travels through the chamber, you have this sort of swirling, chaotic electrical activity. And there's really three reasons that you care about atrial fibrillation. The first is because it might make you feel badly. The second is your heart rate can go very quickly in atrial fibrillation, and when your heart goes quickly, that can damage the bottom chamber of the heart if you do that all the time. And the third reason is that atrial fibrillation increases the risk for blood clot formation and stroke. So when we try and decide what we're going to do about your atrial fibrillation, we have to address three things. The first is, what's your risk of stroke, and do we or don't we need to use blood thinners? The second is, when you're in atrial fibrillation, is your heart rate too fast, and do we need to give you medications to keep your heart rate slower? And finally, if your atrial fibrillation is symptomatic, we're going to want to do something to get you out of atrial fibrillation and keep you out of atrial fibrillation. Let's start with the risk of stroke. There's a lot of misconceptions around the risk of stroke with atrial fibrillation. And I think the best way to think about it is that atrial fibrillation is associated with an increased risk of stroke rather than that atrial fibrillation causes an increased risk of stroke. And the reason I emphasize it that way is that it does not seem to be true that if we make your atrial fibrillation go away, we make your risk of stroke go away. So if you have an increased risk of stroke, and we'll talk about how we decide that, but if you have an increased risk of stroke, you need to be on blood thinners whether or not we can cure your atrial fibrillation. And I think that's probably the most common misconception. People come for treatment of atrial fibrillation, and they think that if we can get them and keep them in normal rhythm, they won't need blood thinners anymore. Sadly, that's not true. So how do we decide if you need blood thinners? Well, the answer is that your risk of stroke is associated with what other risk factors you have for stroke above and beyond atrial fibrillation. And those risk factors include things like age greater than 65 or 75, female sex, abnormal heart function or valvular function, diabetes, high blood pressure, vascular disease. If you have two or more of those things, it seems that you would do far better to be on chronic blood thinners than not to be on them. If you have none of those risk factors, just atrial fibrillation, your risk of stroke is really not that high, and importantly, blood thinners don't reduce the risk significantly, and so you don't need to be on blood thinners. And if you have one of those risk factors, the data is a little mixed. Some studies say you do better on blood thinners. Other studies say that you don't do any better, and the American Heart Association essentially says, I don't know, you really have to decide on a case-by-case basis. We don't treat everybody with atrial fibrillation the same. For people who have no symptoms, we don't have to control their atrial fibrillation. We don't have to keep them in normal rhythm. We do have to make sure that their heart doesn't go too quickly while they're in fib, because that can damage their heart. But that's relatively easily accomplished with fairly benign medications. Only in people who have symptomatic atrial fibrillation do we really work hard to get them and keep them in normal rhythm. We have two options. One is medications called antiarrhythmic drugs, which alter the electrical properties of the atria in an attempt to keep them from fibrillating. Unfortunately, those drugs don't work very well. They work in about 45% of people. And even in the people in whom they work, it's not uncommon for them to work for months or years and then stop working. Which is okay. If we can control your atrial fibrillation with medication, we'll do that for as long as we can and look for alternatives if and when the medications stop working. Luckily, there is an alternative, and the alternative is called catheter ablation. It's an interventional approach to atrial fibrillation, but it's not a surgery. There's no knives or stitches involved. We put wires through IVs and thread those wires up into the heart, and we can heat tissue with the end of those wires in a process called electrocautery, which can create scar tissue. Scar tissue doesn't conduct electricity, and we alter and constrain how electricity can flow through the heart. Ablation isn't perfect either. It doesn't work in everybody, but it does work in about 75% of patients. There's some fine print involved, however, which is that It's not uncommon to require more than one ablation procedure in order to fix somebody. So only about 50% of people are cured with a single procedure, and the other 50% can require 2 or 3 or even more ablations in order to get them and keep them in normal rhythm. If your atrial fibrillation isn't bothering you, we don't need to treat it with medications or with ablation. But what we do need to do is make sure that your heart rate isn't too fast in atrial fibrillation. Typically, that's relatively easy to do. We can use benign medications called beta blockers or calcium channel blockers to slow the heart rate down. Sometimes we find that either there isn't enough of that medication to slow your heart rate down, meaning we give you a lot of medicine and nonetheless your heart rate is fast, or there's no sweet spot, if you will. We give you enough medicine to slow your heart rate down, then you're going too slow, so you're either too slow or too fast. In the unusual circumstances where that happens, we have an option, and that is we can implant a permanent pacemaker, which isn't fixing your atrial fibrillation. In fact, you're still in atrial fibrillation as much of the time as you would have been without that pacemaker. But what the pacemaker allows us to do is make sure your heart rate doesn't go too slowly, which gives us a free hand to use as much medication as we need to make sure your heart doesn't go too quickly. There's the final, what I call nuclear option, which is if no amount of medication is enough to make your heart rate slow down, which is a pretty uncommon thing, we can do a different kind of ablation procedure, not one where we're trying to fix your atrial fibrillation, but one where we electrically disconnect the top chambers from the bottom chambers. So your top chambers continue to fibrillate, but that electricity can no longer get to the bottom chambers due to our ablation. And then we have to put a pacemaker in, and that pacemaker is what's going to drive the bottom chambers of your heart all the time. So if you have this procedure, what's called an AV node ablation, you need a pacemaker, and you are completely dependent upon that pacemaker forevermore. So we've been talking about the treatment of atrial fibrillation in the long term. There are times when you'll treat atrial fibrillation acutely. If you're having atrial fibrillation and it's very symptomatic, you present to an emergency room, they'll typically do a procedure called an electrical cardioversion, where they give you some medicine that puts you to sleep for just about a minute or so, and they pass electricity through the chest with paddles like you sometimes see on TV. And that'll shock the heart and get it back to normal rhythm. But that procedure doesn't do anything to change the properties of your heart. You're no less likely to have atrial fibrillation a minute later or a year later than if you hadn't had the cardioversion, but it can get you out of an episode acutely. So just to review, there's 3 things that we need to address if you have atrial fibrillation. If it causes symptoms, we're going to try and fix your atrial fibrillation, either with medications or with an ablation procedure. But if it's not causing symptoms, we don't need to do that. You can stay in atrial fibrillation. Regardless of what we do about your rhythm, we need to make sure that we're addressing your risk of stroke. We decide what that risk is based upon your risk score, taking into consideration things like your age, your sex, whether you have high blood pressure or diabetes or valvular disorder or vascular disease. If you have 2 or more of those things, you require blood thinners. If you have none, you don't. If you have one of those things, we really need to decide on a case-by-case basis whether or not you need blood thinners. Finally, if you're in atrial fibrillation and your heart rate is very fast, we need to do something to control that. We can typically do that with very benign medications called calcium channel blockers or beta blockers. There's one last caveat about blood thinners, and that is the risk score story that I was telling you about really addresses lifelong risk of stroke and need for blood thinners. There will sometimes be a transient increase in your risk of stroke, and if you have a transient increased risk, you'll need blood thinners for that period of time. Classic example is when you've had a cardioversion where we shock your heart to get you back in normal rhythm. Your doctor's going to want you on blood thinners around the period of time of that cardioversion. And if you have an ablation, you'll need to be on blood thinners for the period of time after that ablation. So in conclusion, if you want more information about the ablation procedure in particular, you can watch our companion video about AF ablation.